to Dr. Vincent Cottin from University of Lyon and talk about a really important phenotype in IPF, in combination with emphysema.
Thank you very much, and I'd like to thank Luca and the organizers for the invitation to give this overview of what is known about the impact of emphysema in patients with pulmonary fibrosis. Well, here are my disclosures. So one of the first studies published about this issue was published by Margaret Turner Warwick in the 90s, showing that patients with fibrosis and with emphysema had preserved FEV1 FVC ratio, preserved TLC, but very low DLCO. And this is in only 9 patients. There is also another work from the UK showing the pulmonary function of these patients. And later on, Athelwells has published a comparison of patients with or without emphysema in the context of what was called CFA at that time, and showing that in 14 patients with emphysema and fibrosis, that although the amount of fibrosis was similar between these groups, or almost similar, there was marked differences in the pulmonary function, with higher lung volumes in patients with emphysema on the left as compared to those without emphysema on the right, with, on the opposite, lower values for DLCO in patients with associated emphysema. So he concluded that the emphysema on the CT was a marker for smoking-related functional impairment. And based on this work, he has developed the CPI, the Composite Physiologic Index, which I remind you is derived by fitting the pulmonary function test against the disease extent on the CT, and which permits to reflect the extent of disease more accurately than the individual lung function indices, predicts mortality, and corrects for the effect of emphysema. And you know this formula based on DLCO, FVC, and FEV1. So we took, emphysema in IPF patients is not rare, actually. From this recent review, it was considered to be present in 18 to up to 50% of patients with pulmonary fibrosis, depending on the criteria you use. And we took a different approach. Instead of using the statistical analysis of a cohort of patients, we analyzed individual patients with significant emphysema, and we selected specifically patients in whom we considered the emphysema was really prominent on the imaging in association with fibrosis. And we did not restrict to patients who fit the definition of IPF, but included patients with some features of fibrosis and prominent emphysema. And for that study, it was emphysema only in the upper lobes, and we'll see examples where emphysema or emphysema-like lesions can be in the lower lobes. In these 61 patients, the mean age was similar to what we see usually in IPF, but all were smokers or ex-smokers with a mean of 46 pack years, and all had dyspnea with about half class 3 or 4 dyspnea. Most of the patients had crackles, and a bit less than half had finger clubbing. And we found a similar pulmonary function test with normal FVC as a mean in the group, normal TLC, but very low DLCO and transfer coefficient in this group of patients. And obviously they had hypoxemia, which worsened with exercise. So this syndrome of combined pulmonary fibrosis and emphysema is a cause of very severe reduction in transfer capacity. This is a work from the Mayo Clinic showing that out of a very large group of patients who had pulmonary function, if you select those with decreased TLCO yet normal lung volumes, out of the small numbers who could be evaluated, about 22% of these had CPFE. So it is a cause that you can find in series of very severe alteration of DLCO. Next, we tried to figure out if they had some specific features on imaging, and we could separate into 3 and maybe 4 patterns on imaging. The first and self-evident pattern is coexistence of some emphysema features in the upper lobes with fibrosis, and here is a nice honeycombing lesion in the lower lobes, but not much interaction or overlap between both entities. Second would be progressive transition between emphysema in the upper lobes with more fibrosis in the lower lobes, with some overlap in some slides here. The emphysema being both centrilobular and paraseptal. And of course, this could be only worsening of the previous pattern, possibly. And a third pattern we believe is more peculiar is where there is predominance of the paraseptal emphysema still with thickening of the interlobular septa. And there is some interstitial changes here that remain if the patient is in a prone position, but there is no actual honeycombing in the lung basis. Paraseptal emphysema, we believe, is characteristic of this association of fibrosis and emphysema. It is known it is associated with tobacco smoking, but it's not so common actually in COPD. And it may be associated with less airflow obstruction as usual emphysema. And the last pattern is a variation of those with paraseptal emphysema and fibrosis, where we see large holes, cysts in the lung basis, but with some fibrosis around these cysts. And this is too large to be the usual honeycombing. If you look back into the definition that Hathel, for example, used in his paper, he used emphysema distinguished from honeycombing by the absence of well-defined walls in areas of bolus destruction. And obviously, you cannot use this definition here to define it as emphysema. This is difficult to describe, and in the literature, you find some close examples, and this one is histiocytosis, histologically confirmed, and this was considered by David Hansel as a large cystic airspace within honeycombing in IPF. So I'm not sure how we should name this. This is my point, and we should be careful that in some cases this might correlate with histiocytosis lesions. So to try to understand how these lesions may be built, we've collaborated with Belazuki in Boston, who has a nice model of the lung being a network of springs, each of the springs representing an alveolar wall. And you randomly select some of the springs to increase their constant, and you repeat this process several times. And at some points, you see holes coming into the model of lung, and eventually larger cysts with some possible thickening around the holes. So this is just an approach to try to model how these large cysts may come up in the lung. Some correlation with function: the more emphysema, the higher the lung volume; the more emphysema, the lower the FEV1 FVC ratio; and conversely, the more fibrosis on the imaging, the lower the TLC; and the more fibrosis, the higher the FEV1 FVC ratio. So this helps to understand how both emphysema and fibrosis combined may compensate each other, possibly. This is, to me, a very important work that has been published by a Japanese group, showing that actually patients with both emphysema and fibrosis have less changes over time in their lung function. Vital capacity changes very little over time in patients with both fibrosis and emphysema as compared to those with fibrosis alone. And this is the same with DLCO. So this impacts how we could follow patients with CPFE, and also it does impact the potential use of DLCO and vital capacity as endpoint in clinical trials. So those patients may not be relevant for clinical trials. So how much emphysema is enough to impact pulmonary function? We don't know for sure. This is a work from the Michigan group, where they arbitrarily defined mild emphysema, which is count, moderate emphysema, which is as much as fibrosis, and severe emphysema, which is predominant, and emphysema being more important than the fibrosis. And when they evaluated this on a large group of patients, they found that half the patients had some emphysema, but if you only take the group of moderate to severe emphysema, it's a fourth of the patients who have moderate to severe. And if you now follow them over time and try to define what is predicting the outcome in these patients, it's not DLCO, it's not FVC, but the change in FEV1, which is predicting prognosis in these patients with a lesser prognosis, lesser survival in those who decline in FEV1. This has to be confirmed in other cohorts. Briefly about pathology, I won't review it in detail. Most of these patients, when evaluated, have a UIP pattern, but a variety of other patterns have been described in these patients, including NSIP. And the Brampton group has performed an imaging and pathology study in those patients with both emphysema and NSIP confined on the, I think, imaging only. And what is striking is that if you compare smokers with fibrotic NSIP to COPD patients used as controls, they have as frequently as COPD patients some emphysema features at imaging. To me, this is striking, and there are only 18 patients with NSIP pattern, and usually emphysema is mild, as in this example, where there are some emphysema lesions within the NSIP pattern. To come back to our study, we had unexpectedly high number of patients with some ground glass at imaging. Remember, we didn't really apply IPF criteria, so it might be that we have a number of patients with NSIP actually in cohorts. And this issue of the pathology is not trivial in these patients because it may impact how we interpret them. This is an example from a Japanese study showing that in this patient there are cystic changes that could look like honeycombing. And this is actually a histologically confirmed NSIP and disappears, the interstitial changes disappear upon corticosteroid treatment. So in a patient with emphysema, to have interstitial changes is difficult to interpret and may look like UIP, whereas it's a more inflammatory and possibly reversible process. So, of course, there is some interaction between emphysema and fibrosis. It's not self-evident to know which is first. In most of the cases where we had the information, emphysema preceded the onset of fibrosis. But then fibrosis may modify the progression of emphysema, and the emphysema may also modify, as we have seen, the pattern of fibrosis, and also they may modify the pulmonary function. So it might be that in some cases, mild interstitial changes appear in patients with COPD. This is from the COPD gene study, where over 2,000 CT scans were evaluated in smokers, and 8% of them had some ILD changes. So I don't have a detail of the pattern of the imaging in these patients, but what is interesting is that the red dots here, which correspond to those patients with ILD changes in smokers, very often do not fit criteria for gold criteria. And we found the same in our cohort. This is from 3 merged studies. Actually, almost 60% of patients with CPFE do not fit the gold or the gold 2009 criteria for COPD, meaning that they do not have FEV1 FVC ratio below 0.7. It might be that some patients do have COPD with mild interstitial changes, and we do not see them yet on the imaging. This is a pathology study from 1998 showing that if you look at the pathology of emphysema, there are some alveolar walls which are thickened, and this is confirmed by electronic microscopy, where there is some deposition of collagen in those patients who have been diagnosed with only COPD and emphysema. And actually, the pathologists do describe this. If you look at lobectomy specimen in patients who are smokers, who have lung cancer, and you look at the distal interstitial changes, there are some features of fibrosis, although they had not been diagnosed on the CT. And this is another example where there is some mild honeycombing in a smoker, which have been described as fibrosis superimposed on emphysema. The pathologists have described these using different terminology. I'm not a pathologist, but these eminent pathologists may well describe some at least overlapping abnormalities in these patients, being mild interstitial changes in patients with emphysema. Going now to the prognosis of these patients, this is the overall survival in the cohort, with 55% survival at 5 years, with pulmonary hypertension being the main determinant of the long-term survival in these patients. This is, in this study, pulmonary hypertension at echocardiography, which was present in almost half the patients. But then once they have pulmonary hypertension, and this is now confirmed pulmonary hypertension at right heart cath, they do have a very poor survival with only 60% survival at 1 year, with the cardiac index being the main determinant of survival once they have confined pH, and the median here was 2.4. There are some potential for acute exacerbations in these patients. We have encountered a few, but there are no data yet about the prevalence or incidence of acute exacerbations in this subgroup. But 2 recent papers point out that patients with emphysema and with low DLCO and with pulmonary hypertension are at a higher risk of acute exacerbation. So it may be that those patients with CPFE who have all these criteria are at an increased risk of acute exacerbation. Another complication that they may encounter is lung cancer in association with both emphysema and fibrosis. There are not many data yet, but I'm citing only one study here. This is a Japanese study showing at radiology reports, so they did not review all the imaging, but the reports from the radiologist from over 1,000 patients who had surgery for lung cancer, and expectedly about a third had emphysema on the report. A small percent had some fibrosis related on the report, but 9% had both fibrosis and emphysema rated on the report. And those patients with both emphysema and fibrosis have very poor prognosis, possibly because the severity of disease had been under-evaluated because of normal lung volumes in these patients. So usually they have emphysema first. After some years, fibrosis may develop, then pH and possibly cancer, and from then survival is very poor. However, whether the emphysema does impact survival in those patients with actual IPF is very controversial because of difficulty to assess for severity of both emphysema and fibrosis. And I borrowed this data from Chris Ryerson, who has presented at the ATS a nice study showing evaluating the prevalence of prognosis of CPFE using standardized definition. This is based on 2 IPF cohorts, and emphysema and fibrosis were scored by 2 radiologists, and CPFE was defined arbitrarily by more than 10% emphysema at imaging. The first result is that 8% in these 2 cohorts had emphysema. Remember, this is US. We would have much more, unfortunately, in Europe. And this is from the threshold of 10% emphysema at imaging. Also, as expected, patients with CPFE had higher FVC. They also had lower fibrosis score and greater oxygen requirement. And if you look at the survival now, there is no difference between patients with IPF and patients with CPFE in these cohorts, even when adjusting for fibrosis severity. The main issue with this work is that the 10% threshold is, of course, arbitrary, and it is unknown whether it is really the relevant threshold yet. Regarding etiology, most of these patients, 98%, are smokers or ex-smokers in this recent review, but there are other etiological factors which can lead to develop both emphysema and fibrosis. How smoking can cause either COPD, emphysema, or fibrosis, or both, is not known yet, but there are likely an imbalance between some of these factors and many others, which probably explain, and some common pathways between both, which can likely explain this occurrence. But there are also inflammation issues in these patients, because, for example, CPFE can occur in patients with connective tissue disease. This is in a patient with rheumatoid arthritis, and rheumatoid arthritis is the main CTD that can give rise to this pattern, but systemic sclerosis and the other connective tissue diseases also can give rise to this. If you compare CPFE in connective tissue disease on the left to the common interstitial lung disease in CTD without emphysema on the right, you, as expected, find higher lung volumes and lower DLCO in patients with emphysema associated. And this may be more than an association, at least in some of the patients. This is a 28-year-old woman. She has smoked very little, and she, however, has prominent emphysema changes in the upper lobes and some interstitial lung disease, which is actually currently worsening. Other etiologies have been described. I don't have time to review them all, but there are some occupational etiologies and also some genetic background, which is actually suggested by cases like the one I've just shown. First argument is that there is a very strong male predominance that may not be completely explained by the tobacco smoking history. Second, there are cases like this one of combined pulmonary emphysema. There is emphysema, I'm not sure it projects, in these patients with SFTPC mutations. So there are some examples of mutations associated with CPFE. And as we have heard previously, there are some arguments pointing toward the role of telomeres in patients with both emphysema and fibrosis. Regarding management, there are no specific measures that we can propose to these patients, and there are no specific trials ongoing in those. But again, I'd like to point that the IPF trials may not be adequate because these patients, as we have seen, do die at some point, but mostly from pH, but they do not have severely decreased lung volumes. Smoking cessation, obviously, is crucial, and lung transplant is one of the supportive treatment we can offer them. Currently, we use NAC in these patients, but we also discuss in some cases steroids with ethacillopyrin, especially in those who have a lot of ground glass opacity, since some of them can have an SIP pattern, although they do not have a lung biopsy. It might be worth trying some of these treatments. What is really open to discussion is the role of PAH treatment in those patients, especially those who have out of proportion or so-called out of proportion pulmonary hypertension. It is currently recommended to enroll them in trials, but there are very few trials for these patients. So we do avoid unprecedented since the Artemis trial, and we enroll them in a prospective registry of patients with ILD and pulmonary hypertension. This is data presented at the ERS this year. And out of 176 patients included, 36 had a mean pulmonary pressure greater than 35 millimeters of mercury and had some treatment off-label in this prospective registry, including 8 with CPFE. And this is data from the study 6. So there are CPFE, but there also are some IPF, systemic sclerosis, and sarcoidosis patients. But the message here is that with treatment, there is some decrease in the mean pulmonary pressure. There is some increase in cardiac index, some decrease in the pulmonary vascular resistance, but the 6-minute walk test doesn't change significantly. So the hemodynamics can change, but the clinical relevance at this point has not been demonstrated in these patients. To summarize, the association of emphysema to a patient with fibrosis defines more a syndrome that really a specific disease or condition, but there is a characteristic presentation. It can be overlooked because of the subnormal spirometry. However, gas exchange and diffusion capacity are severely altered, and we need to evaluate gas exchange in patients with severe dyspnea. The diagnostic criteria for UIP are less applicable in these subgroups, and the prognosis is mostly related to pulmonary hypertension, maybe lung cancer. There are some specificities for follow-up, for trial, and these may be confusing in IPF trials, and the pathogenesis is challenging with common pathways involved in both. And this is my last slide with some of the number of unresolved issues and challenges in these patients, and we'll try to address some of them. With obviously the pathogenesis beyond smoking, and especially is the male predominance only linked to the smoking history, or is there some unknown other factor? We obviously need a better definition of CPFE, which is how much emphysema or which phenotype of emphysema are sufficient to impact the outcome and merit individualization. And if so, how does emphysema impact the progression of fibrosis? And this is only, not only on the pathogenesis, but also on the pathology, on the change in lung function. Little is known on the long-term outcome. Are some phenotypes of CPFE and maybe as clusters relevant? Meaning, do they impact the long-term function and the outcome differently? And especially, do these patients with thick-walled large cysts have a different outcome? We don't know that. And obviously, the therapy, very little is known, and we currently manage separately the pulmonary fibrosis, the emphysema, and the pulmonary hypertension, but very little is known in these patients. Thank you for your attention.
That was wonderful. Do we have any questions? Particularly the paraseptal emphysema being called UIP is something that's great. You're drawing attention to that. Very important. Hal?
Thanks, Vincent. So I just had a comment about treatment, and this is something that Chris looked at in the cohort from UCSF and Mayo. So the issue of acute exacerbation. So about half of patients who, at least radiographically, met criteria that might qualify for bronchodilator therapy weren't on bronchodilator therapy. And I've often thought that therapy probably isn't that important in patients with lung fibrosis, but maybe that is helpful or could be helpful in preventing a COPD exacerbation that could lead to increased stress and an acute exacerbation of pulmonary fibrosis. So I think your talk made me think about that a little differently, and that may be an issue where this is important to recognize and treat the emphysema, which may have an impact on the fibrotic disease. So anyway, thank you for making me think of that.
Thank you for your comment.
Yeah.
Professor Ricaldi.
Himself.
Yes, I'm recovering, and I asked a question the last day.
Too far over time, you're closing us down?
So Vincent, I think, I mean, that was a great presentation. I think there is still the point, are these patients with IPF? I think it's crucially important because at the moment the presence of emphysema, as you define it, pointed out, is not an exclusion criteria in the diagnostic criteria of the current guidelines. So when we look at the high resolution CT scan criteria and look at the features which are not supportive of a UIP diagnosis, the presence of extensive emphysema or of some emphysema is not there. So you can have any emphysema. So that I think it's extremely crucial in the context of the population that we are enrolling in clinical trials. In particular, it looks like if you want to design a trial with the primary endpoint survival, it will be better to include these patients if they have IPF. On the other way, if you are designing a trial on FVC decline, these patients may make your endpoint more difficult to be reached. So I don't know, of course I don't have an answer. I just want to elaborate on that. And the final concept is the following. The fact that we define this patient with emphysema is like they have a disease that we know has pulmonary emphysema. Should that be real emphysema or is more something like airspace enlargement? Is something that is not real, the real emphysema that we know as we define that? That's all.
Very nice. Well, I basically agree with you. We need some more specific criteria, and some of these patients likely do not have IPF as we currently define it. But then, having said that, it's very difficult to move forward and define them differently because very few of them have pathology. We've trying for years to do a pathology on these, but very few have a lung biopsy because of this very existence of emphysema. So to try to correlate imaging and pathology first, which is obviously important to devise criteria for IPF emphysema on one side and NSIP emphysema on the other side, for example, is very difficult because you don't have a large cohort with a biopsy to study that. So yes, we need that, but my belief is that it will be more likely done on better imaging criteria than on pathology correlations. So what we need is to look at specific features of emphysema and associations of emphysema and fibrosis and look if it's predictive of a particular outcome. Are some of them more at risk to develop pulmonary hypertension? Or some of these more at risk of death? We don't know that yet. For the comments you had on the endpoints in trials, I absolutely agree. And I forgot the third and last point.
Should we call it emphysema or with another word? I mean,
well, I think this is more a discussion for pathologists, and you've seen there are almost as many terms used as patients biopsied. So I'm not sure we need to decide at this point. And I would let the eminent pathologist decide it.
Kevin?
Vincent, thanks for all your elegant work. So you've taught us about the excess of pulmonary hypertension in these patients, and I've always considered that probably some combination of the abnormal vasculature and fibrosis combined with the loss of alveolar-capillary interface in the patients with emphysema. But during your talk, it started to make me think whether there was actually some primary vasculopathy that also complicates this disease, and whether you think the excess pulmonary hypertension might be something more than just loss of vascular space in these folks. Can you just speculate on that?
Like you said, it's a speculation, but thank you for asking. Yes, I believe, but this is personal, I believe there is more than just coexistence to determine the occurrence of pulmonary hypertension. First, on the pathogenesis, smoking has been shown to induce pulmonary hypertension and to induce the changes that lead to pH in patients. So it might be that just independently of COPD and fibrosis, just to be a smoker contributes to pulmonary hypertension. And secondly, among all these patients who develop PH, some of them do not have severe fibrosis and do not have severe emphysema. So yes, they have both, so they have less capillary volume, but I'm not sure this is the answer to it. The PH world is trying to define criteria for out of proportion pulmonary hypertension as compared to the lung volumes, and they are having a hard time doing that. Even in patients with just IPF or just emphysema, because we don't exactly know how much pH you should normally expect from a certain level of emphysema or a certain level of fibrosis. So I don't know what level of pH you should expect when you have both on severity of which you cannot exactly evaluate.
I think, yes, I think that one important consideration of your presentation and other presentation related with acute exacerbation is that we used to believe that these are phenotypes or something that occur in IPF, but not. A pulmonary emphysema occurs also, as you show, in patients with interstitial lung disease for arthritic rheumatoides, or also in hypersensitivity pneumonitis, chronic. So emphysema is occurring in smokers with several kinds of interstitial lung disease. Also, acute exacerbation has been described in IPF, of course, but in other interstitial lung disease that evolve to fibrosis. So perhaps we should be careful when we are talking about phenotypes in IPF. These are some kind of phenotypes or comorbidities associated with pulmonary fibrosis, at least some of them.
Well, I absolutely agree. I think, we don't have criteria yet to define if it's IPF with emphysema. In your study, for example, you defined IPF and then you looked at emphysema, and Chris Ryerson did so. But I think it's restrictive because there are plenty of patients who do not fit correctly these IPF criteria, and still they do have emphysema associated, and they have the same phenotypes in terms of developing PH, developing all the same complications. So I think the criteria are not mature, but I think it would be restrictive to define that only as pure IPF with associated emphysema. We would miss half the picture. Maybe.